Welcome to this webinar on COVID-19, Early Lessons from Africa. This webinar is convened by the Africa Centers for Disease Control and Prevention and FHI 360. First, let me introduce myself. Dr. Doris Macharia, FHI 360's Regional Director for Eastern Southern Africa, and I will be facilitating the discussion with our panel of health experts who will reflect on the state of COVID-19 preparedness in Africa. What we currently know is that COVID-19 has followed a predictable epidemic trajectory in Africa. Initial confirmed cases were travelers from high-risk countries, their contacts, and now there is ongoing community transmission. We are also cognizant of the challenges in our healthcare system, given our overstretched budgets and other competing demands. Limited and suboptimal investments in infectious disease pandemic preparedness has further confounded our responsiveness in terms of our healthcare system. Even though the number of COVID-19 confirmed cases and deaths in Africa is much less than Europe and North America, and by early this morning, there were just over 25,000 confirmed cases and in excess of 1,200 deaths. But it may be too early to celebrate. There is still a lot more that we don't know about COVID-19. COVID-19 is pushing Africa to a kind of renaissance that really requires us to leverage our existing national health programs and platforms, such as HIV and TB, and also adapt global COVID-19 guidance to our local context. These are some ingredients for a sustainable COVID-19 response and the main areas for our discussion today. I will now introduce our panelists for this webinar. And after I introduce them, I'll ask them to just quickly give some quick remarks. And please, they must tell us why they remain optimistic during these COVID-19 uncertain times. So first things first, Dr. Ahmed Ogwel Ouma, he's a senior civil servant and public health expert. He has been a pioneer in supporting governments to implement WHO Framework Convention on Tobacco Control. He served as an advisor in the global coordination mechanisms for non-communicable diseases in WHO. And in Kenya, Dr. Ogwel was the founding director of the Ministry of Health Division of Non-Communicable Diseases. Dr. Ogwel is currently the director of Africa Centers for Disease Control and Prevention, a technical agency of the African Union. Dr. Ogwel?
Thank you very much, Doris. And it's really a pleasure to be here to share, particularly something like COVID-19, which is a very different sort of outbreak, what the world has seen in ages. So it's a pleasure to be here, and I'm looking forward to the discussions.
Thank you very much, Dr. Ogwel. And then moving on to Professor Lashley Abimiku. She is a scientist known for her HIV research and work to strengthen laboratory medicine in Nigeria and throughout Africa. In 1993, she was first to demonstrate the prevalent HIV strain in Nigeria as subtype G. She was also the first to establish a reliable HIV research laboratory in central Nigeria. Professor Abimiku serves as a member of the International Scientific Advisory Group for the Coalition for Epidemic Preparedness Innovations. She also serves as chair of board of directors for the African Society for Laboratory Medicine. Professor Abimiku is a co-founder and executive director of the International Research Center of Excellence and Institute of Human Virology in Nigeria. She's also professor at the Institute of Human Virology at the University of Maryland School of Medicine. Professor Abimiku?
Thank you, Doris. It's a pleasure to be part of this panel. Good morning, good afternoon, everyone in Africa. I look forward to the discussion. Thank you.
Thank you very much. Professor Gavin Churchyard, he is a specialist physician He is internationally renowned for his contributions in tuberculosis research. He is an honorary professor at the University of Witwatersrand and the University of Cape Town. Professor Chachad is the chair of the AIDS Clinical Trials Group, Transformative Science Group for TB, chair of the Cross-Network TB Vaccine Working Group, and a member of the AIDS Clinical Trials Group Chemical Entities Working Group. Professor Chachad has more than 260 publications and has served on many WHO expert committees. He is founder and group chief executive officer of the Oram Institute, which is an independent, not-for-profit, proudly South African public benefit organization that focuses on TB and HIV, technical assistance, service delivery, and research. Professor Chachad?
Well, thank you so much for inviting me to be part of this really important panel discussion. So COVID-19 brings with it lots of challenges in the African setting, but it also brings amazing opportunities. And so while we're responding to the challenges, we also need to grasp and exploit the opportunities that it brings. And so I look forward to sharing some thoughts on how we can do that. Thank you.
Thank you very much. And lastly, my good colleague, Dr. Otto Chabikuli, who is a family physician and health system policy analyst. He has directed global research and technical programs in leadership positions at FHI 360 for over a decade, and covering topics like HIV and AIDS, family planning, tuberculosis, nutrition, laboratory strengthening, and emerging infectious diseases, among others. Dr. Chabikuli served as the regional director for FHI 360's work in East and Southern Africa, and also as country director and chief of party for FHI-led Global HIV/AIDS Initiative Nigeria project, which is also called GAIN. He recently held teaching appointments as an associate professor at Howard University and Sefaho Mahato and Walter Sisulu Universities in South Africa. Dr. Chabikuli is currently director for our Global Health, Population and Nutrition at FHI 360. Otto?
Thank you very much, Doris, and good morning, colleagues. It is my pleasure to be part of this great panel to share early lessons coming from Africa. I would like us, during this conversation, I'm going to share my observations taking HIV as a lens on describing the capacity gained during the decades of fighting various epidemics. And I would like to argue that this is really a great basis on which we can build Africa response, but also to preserve the gains that we have made over these decades so that we don't lose what we have already achieved in these areas. Thank you very much. Looking forward.
Thank you very much. And we really look forward to engaging our panelists in a few minutes. But to start us off, we'll start with a short presentation from Ms. Li Ling. Li Ling is a public health specialist. She has worked in the public health arena in China for more than 2 decades. And her special focus is infectious diseases, including multi-drug resistant TB, HIV care and treatment. Li Ling is currently FHI 360's China Program Director for USAID's CAP TB project that is combating multi-drug resistant TB in the Greater Mekong sub-region. She will briefly share how the project successfully supported care and treatment of MDR TB patients during the COVID outbreak in Wuhan. Over to you, Li Ling.
Okay, thank you. Thank you, Doris, for giving me these opportunities. And I'd like to thank USAID for continuing support CAP TB project. And today I'm going to share the FHI 360 work in Wuhan during this COVID-19 outbreak. Next, please. Next slides, can you? Okay, thank you. So CAP TB project is a USAID funded project that has operated in China for almost 10 years. We have a very small team here, only 8 staff, And we worked with China CDC and the National TB Program on MDR TB care and treatment in 30 provinces in China. Next one, please. So when COVID-19 outbreak happened, people have to stay at home. Our transportation was restricted. You can see the empty streets anywhere in our city. So MDR TB patient was worried. They don't know how they would be able to get their treatment. So we worked with our partners for emergency TB services across 7 provinces. But here we're mainly focused on Wuhan City, the epidemic center, where at that time in Wuhan, the health system overwhelmed. The entire city was shut down. So what we did, the first one is we developed this emergency patient care flow and analyzed the data to identify the patients who are running out of the TB drug. So our peer workers conducted the MDR TB patients, collect the needs from them, and then we helped our health provider to come up with the emergency plan for delivering these mobile TB services. You can see the 2 pictures here. We helped our patients make appointments so they can meet our health provider at the township highway to get the drug and also collect the blood. So our MDR TB patients could still get the critical health care even though they cannot travel to the hospital. So the last one is we use the social media to provide the emotional support for our patients and also our health provider. So we found that one of the hardest things about the COVID-19 outbreak was the isolation. So people feel so frustrated sometimes. And we worked to ensure that our partners and the patients knew they were never alone. So during the outbreak, we will be able to directly support more than 168 MDR TB patients in Wuhan. And our 97% MDR TB patients who started treatment in Wuhan Jingyintang Hospital right now are still on treatment today. So next, please. So on April 8, Wuhan opened the door. So shortly, we received a very special gift from our partner, Wuhan Jingyintang Hospital. The Red Book was illustrated by an artist, talk about the real story of Chinese people, how we're coming together to help each other, and also a PPE set signed by everyone in the hospital with their thank you notes. Next one, please. So that's the message I want to share with all of you today. We are in the difficult times, but just remember, we are not alone. We use our resources to support each other. Like our health provider in Wuhan said to us, better days will return and we will meet again. We have made it in China. We know that you can do it as well. Thank you everyone for your listening. Thank you, Doris.
And thank you very much, Li-Ling, for sharing those really remarkable experiences that looked at leveraging TB programs to really support patients in terms of treatment and care and support. Now, I want us to turn our attention to discussing how Africa can adapt the global COVID-19 guidance to our local realities and context, because that is critically important, especially regarding testing and tracing policies, utilization of community healthcare professionals, and as well as the implementation of social distancing in informal and peri-urban settlements. To start us off in this discussion, I'm going to call upon Dr. Oguel. And perhaps, Dr. Oguel, can you tell us What are your thoughts on the 3 T's policy with regards to COVID-19 in terms of tracing, testing, and tracking, and the applicability in countries like Kenya and other countries in Africa?
Thank you, Doris, and good afternoon, everyone who's on the webinar. I think there is absolutely no, we should be seeing large numbers, because we started this journey of the outbreak a lot later than all the other regions of the world, meaning we have learned some lessons, and it is quite important that we put those lessons to good use. Now, the 3 T's, it's very clear that what we need to do as Africa is to stay ahead of the curve, and that way limit the numbers and therefore protect our very fragile health systems. We as Africa CDC, from the very beginning, when we first realized there was an outbreak in China, started building the capacity of governments to enhance the surveillance at ports of entry, and therefore be able to pick out any cases that met a certain definition. Second is, apart from ensuring that we can be able to pick the possible cases early, it is to test them. And these will ensure that we get to know who is exposed, isolate them. That way they cannot be able to transmit to the rest of the community. And then the 3rd T is to actually trace whichever contacts they may have exposed as well, all in an attempt to keep the numbers low, and those low numbers are well secured wherever it is that they are found. So as Africa in general, we have seen governments come out and respond quite rapidly. A lesson that we learned very well during the Ebola crisis in 2014 in West Africa, that we need to act quickly. And when we act quickly, we act with the appropriate public health tools and science that has been proven to work. And this has really contributed to the low numbers in Africa. And although the graph is inching up, it is not as steep as we are seeing in other parts of the world. The other thing that we need to ensure we are doing in Africa, apart from doing effective testing and isolating those we find to have the virus, is to keep members of the public properly informed, give them correct information, give them the information in a timely manner, and encourage the members of the public to participate in being part of the solution. Indiscipline is what creates chaos, panic, and this will eventually have very many people exposed and eventually infected by the virus. So good, effective communication is very critical. The other thing that I would add here is in 2014, when we had the crisis in West Africa, Africa did not have its own public health agency. The heads of state and government through the Africa Union Assembly decided to establish the Africa CDC in 2015, and by 2017 it was up and running. So when this particular outbreak has come, Africa has a public health agency. Africa has the ability, much better than before, to be able to organize itself and deliver support to member states where it is required. And this is the other lesson that we've learned, that we must do this thing in a manner of solidarity. All governments, all countries in Africa working together through the coordination of the Africa CDC and the Africa Union, and ensuring that we utilize good neighborliness, where we have regionalized our response so that Africa has been divided into 5 regions, and these regions are then implementing cross-border activities in a very coordinated manner. And this has resulted in us seeing a much better response, much better sharing of resources than we have seen before. The final thing I will be able to say that we need to do is to protect our healthcare workers. We have very few, and if we blink, we may end up with very few, even fewer, that will be able to tackle issues around caring for those who are unwell. So healthcare workers must be protected. They must be given appropriate equipment to protect themselves. They must be given an appropriate environment to do good work, and they must be supported by not only policy, but also urgent action to make sure that they are providing the service that is required to the public. Shifting to Kenya, I would say that Kenya has been one of the countries that has responded relatively fast to this particular pandemic in Africa, instituting public health measures that have shown that if a government acts quickly, it is able to gain relatively good results. Of course, there is still space for improvement. There is still space for better coordination within the country, but it has shown that acting quickly, acting across sectors and across specialities gives results that limits transmission of this virus. And finally, as Africa CDC, we are committed to ensuring that Africa remains working together. We are committed to ensuring that the support that is required by our member states is provided, and we are committed to building capacity not only at country level, but also at the continental level. So the resources we have, be they human, be they laboratory, be they institutions, can be able to be easily shared. And that way, we use homegrown solutions, we use homegrown expertise, and we use homegrown resources to tackle COVID-19. I thank you.
Excellent. Thank you so much. And just building on from that, turning attention to Professor Abimiku, drawing from your own such extensive experience in HIV, virology, with the low confirmed cases that we are all so deeply concerned about, we're seeing in Africa, what would be the real impact of mass testing and contact tracing from your experience?
Thank you very much, Doris. Good morning, good afternoon, good evening. Africa, from wherever you are, I really want to commend Africa CDC and FHI 360 and the WHO in bringing us together to begin to share our experiences and information and lessons learned with each other. I think that is absolutely critical. In terms of testing, I think that we have heard shared by countries that have had to deal with COVID-19 already that the ability of each country to test reasonable numbers of their population to have an indication of the burden of COVID-19, and in addition to the cases they're seeing, is absolutely critical in being able to anticipate and prepare pretty well for the trajectory that it's obviously going to take off. I mean, from past experiences and what we've seen with other countries, we've seen that the cases could be dormant for a little while and then pick up. And in every single situation, it is very clear that when you expand testing, the number of cases shoot up. I mean, and sometimes it's really not the matter of whether the transmission is increasing or whether we're having few cases in Africa. It really is about, are we testing enough numbers to even know where we stand in Africa? So that really has to be critical. COVID-19 is an RNA virus. HIV is an RNA virus. We are very fortunate to have our partners build the kind of capacity within Africa to address the HIV and AIDS and TB problems. And I think that it's really very important that within Africa, we use our limited resources in building the kinds of capacity and the kinds of testing that will be required to really gauge where we are in Africa as far as this a pandemic is concerned. There are a number of issues that Dr. Agrawal brought to bear, which is really very optimistic for Africa in the sense that, you know, we now have Africa CDC that can coordinate responses within Africa, not only coordinate that, but that can also bargain for Africa. Because one of the things that we are experiencing, if the developed countries are having a challenge in getting enough tests to do the adequate number of testing, maybe about 2% of the population. I don't think any country has actually gotten to that limit. So I think one of the advantages that we have with WHO and CDC, Africa CDC, is the fact that they are bargaining with all of the partners that we've worked with. If you look at the COVID-19 test kits that are available, these are partners that we have worked with to deal with HIV. There's the Roche, there's the Abbott, there's the Gene Expert that has to deal with TB, there's the Halogen, and quite a few of them. These are significant partners within Africa that we have worked with, and the African Society for Laboratory Medicine, it's really in a good position, and I'm glad that they are having this webinar every week that bring these partners to the table. But it is really important that, one, we're dealing with partners that we've worked with for the last 2 decades to address the issue of HIV and AIDS. So let's use the platforms. Yes, let's use the experiences from that to really test the numbers we need to test in Africa to get the gauge of where we are, and then to know whether all of the interventions that we are putting in place is actually working or not. At the moment, we don't know that because I don't believe we're doing enough testing. Nevertheless, I do want to commend the efforts of the various governments, Africa CDC, WHO, and even getting some of those test kits distributed across Africa. I want to commend governments of different countries in Africa that have been very responsive. Dr. Agrawal talked about how Kenya has really stepped up, and we've seen in various countries that where the government is really very, very supportive and alert, they've been able to flatten the pandemic. So I'm glad that that is happening, but it's not happening in all African countries. There are those that, in my mind, of the countries that I've interacted with, I think if there is one thing that I think Africa has to do better at, is to take advantage of all its resources within the country. The government is there to coordinate our responses. They cannot implement at the same time. So they've got to look at various associations, whether it's medical, whether it's nurses, whether it's laboratory scientists, and really begin to earmark certain areas and let this group and expertise that is within Africa help them to cope with the issue. I'm glad that Dr. Agrawal has really mentioned the fact that we have homegrown solutions as well. I am very excited, certainly in a country like Nigeria that I'm very familiar with, that is really picking up. We've got masks now that are done mostly in country. They're making enough to ship. We just found out that the military is also getting involved in putting together ventilators and all of that. But let me not digress because we've got other people in the panel that can discuss with that. But that's just an example of so much talent and resources that we have within the continent that we can capitalize on, use it as an opportunity and share with each other. The last thing I'm gonna comment about testing is the fact that the testing, the numbers that we need to test within the continent to get an idea of what we're dealing with comes with some of the challenges that we must pay attention to. So sometimes we talk about testing, but the ability to collect the samples safely, the ability to transport the samples in cold at the appropriate temperature and get it to the appropriate testing sites is just as important. And one of the challenges we have within the continent is the inability to have a really good system that can pick samples from wherever and transport it. So Lillian shared with us how they were able to come to the side of the road and even collect drugs, you know? So I think that that is something that we really have to pay attention to. We cannot have a testing site at every place, but one of the things that will help us to test the numbers that we're supposed to is really to have an arrangement within the country where we can collect samples effectively from rural areas and transport them safely and at the appropriate temperature to the testing labs, so that in the process of transporting, we're not infecting our indigenous. So I just stop there and you know, hear the rest of the discussions. Thank you.
Thank you so much, Professor Abimiku. I mean, that was really great. I mean, you really talked about leveraging. That's what I was hearing, and I'm sure that's what most of our attendees are hearing. I mean, over to you, Professor Churchill. In a recent edition of Science Journal, I noted you said COVID-19 draws on the same skills as HIV and TB, and really that's your area. What does this practically mean in terms of South Africa, especially when you're thinking about community health workers? I think you need to unmute your button, Prof. Thank you. Thank you so much, sir.
Right, let me start again. So Africa has many challenges because of our limited resources, but we really are very fortunate that we can draw on this wealth of experience that we have from dealing with HIV and TB, which obviously the developed countries can't really draw on. And so let me illustrate what some of these advantages are. So with respect to testing, we've already heard the partnerships that we have, but we've deployed gene experts and we have those readily available, certainly in South Africa, and they're now going to be repurposed for doing COVID-19. We've been doing viral load tests and have all that platform available for us to do this. And in terms of actually getting into the communities, getting into households, we need to do this using our community healthcare workers who are well known in our communities. You know, they've existed there for a long time. They've got established relationships and they're trusted by the community. And so therefore, for us to access these communities, provide educational materials to encourage people to come for testing, doing the testing, tracing, going into households, etc., has been surprisingly easy for us to do. And so, you know, these are huge strengths that we can draw on. But not only that, clearly with TB and HIV, there's been a lot of stigma. And we see stigma with COVID-19 as well. People are fearful to come for testing, you know, and they're worried about what that may mean. But again, through the experience we've had with TB, HIV around doing community education, how to brief people and mobilize to overcome this stigma is really important for us to get the scale of testing that we need to get done to impact on this epidemic. So I believe these community healthcare workers are going to be central to our response. Within my own organization, we've deployed over 1,000 of these community testers into communities, into households, and they're screening tens of thousands of people per week because of the relationship they have with these communities. So I think that is an amazing advantage. But it's not just TB, you know, TB, well-established requirements to do contact evaluation. We also do index evaluations within households for HIV-infected persons. And so this provides us with a platform that we just leveraging on again and customizing it for our COVID-19 response. Also with TB and HIV, we've developed all our educational materials, and there's a lot of similarities actually that we can really, it's almost modular. We can take a lot of what we've done, customize it for COVID-19 and move very rapidly. And so we've heard the similarities between HIV and COVID-19, but there's a lot of similarities between COVID-19 and TB in that they are both respirable infections. And so a lot of what we're doing in terms of infection control, social distancing, etc., is what we do for TB. This is not new to us, so we feel comfortable doing this. You know, we encourage the wearing of masks within our TB clinics. Both the healthcare workers wear masks as well as the patients. We're comfortable going into people's homes again to do the contact evaluation. And so it's just this amazing experience that we have. But this also provides us with the opportunity to innovate. So using these platforms is good, but we can then innovate to show what we can do. So for instance, in my own organization, we've developed drive-through testing, and we're establishing drive-through COVID-19 testing. So people don't need to worry about coming into clinics, they just drive through, get tested, and off they go. And seems to be very popular. We're developing really funky community hand washing facilities that also includes thermal temperature scanning. So while they're washing their hands in the community, we're also screening them for their temperatures, etc. And so I think as Africa, we may face challenges, but given our experience with TB and HIV, it gives us a distinct advantage to respond to this disease. And you know, I've found that our staff have engaged. They're concerned clearly, but with the required personal protection, they engage willingly. And I think that's because they've had to do this for HIV and TB as well. They're not paralyzed by fear because they now have to deal with potentially COVID-19 patients. It's part of their job. They are here. They're part of the public health response for TB and HIV. And they have enthusiastically embraced responding to COVID-19. So for us, this has been an absolute privilege to be part of the COVID-19 response and to allow us to innovate. Just one thing I'd also like to comment is, and I think South Africa has been exemplary in this, unlike some of our developed countries, we have seen African countries embrace evidence-based solutions.
Absolutely.
And going for all of government, so the public-private partnerships, and putting this together in comprehensive packages has been spectacular in South Africa. And I think and other countries, it's not just South Africa, but we've seen a leadership emerging in African countries that we haven't actually seen elsewhere. And I think it's something we can be immensely proud of, that we've played that leadership and we are seeing the benefits. You know, South Africa very rapidly bent the curve of the COVID-19 epidemic, and hopefully we'll still keep a lid on it, although we do anticipate the bigger epidemic emerging. But we are ready and we are there to fight this epidemic until we get on top of it.
Thank you so much, Professor Chachet. I think one thing that really reminds me during this COVID-19, I'm sure panelists will agree with me, is everyone knows what exponential is, whether you took a math class or not. So at least it has really, really awakened us to even just the evidence of this particular virus. But I mean, I was also thinking, you know, anyone who has walked the streets of Lagos, Johannesburg, and Nairobi, and many other, you know, streets in Africa, knows how challenging it is to adhere to lockdown. At least I know I'm one of those, and social distancing, particularly in informal settlements. Dr. Chabikuli, you know, what are we learning, and what can we do differently? Yeah.
Oh, thank you very much, Doris. And this is quite exciting. I just closed my eyes and remember New Year 2020 2020, I woke up very excited because 2020 was the year we will be remembering for reaching epidemic control in a number of countries like Eswatini, Namibia. We are really on course to get the number of new infections of HIV below the number of deaths from all causes among people living with HIV. And guess what? This without cure or vaccine. The only reason we got to that point is because of the innovative way we started thinking of how to get the services to people exactly in the context that you have delineated. Anybody who's followed the history of HIV, you will remember when it was just treated in tertiary hospitals, and then the numbers became too much to cater at the tertiary hospitals, and we went to secondary hospital and regional hospitals and primary healthcare. Now we're bringing services all the way to household. And we're talking about differentiated models of service delivery. So I think even social distancing in Africa, and we're already seeing that, we are thinking about different ways of doing that. How do we cater for social distancing in informal settings? In South Africa, I know they're talking about partial lockdowns, for example. In the other places, they're talking about just quarantining those who are vulnerable above 60 years and leaving the economically active people to go about their activities so that you don't disrupt their livelihood. So I think, and that brings me to all the lessons, the good lessons that we can learn from HIV programming. And allow me just to expand a little bit there, because it is only from there that we will mount a very robust response to COVID-19. Now, the past 20 years, there will be tangible and intangible assets that we will have to look at. If we want to look at the number of dollars that were invested, number of people trained, yeah, that's okay. I think that we can quantify and put it in a bucket. But things like trust, things like partnerships, things like embeddedness in community, things like understanding the local context and being accepted so that your intervention become appropriate. Things like just human rights. I mean, I remember in South Africa, they were talking about, let the lockdown or social distancing let the people not be the objects of lockdown, but the subject of it. So you put people in charge of their destiny. And all of that we've done through HIV, the struggle for access to treatment, the struggle for dignity of key population, MSM, LGBT communities and female sex workers and so on. All of that is now part of the fabric of society on which we can mount response against stigma, responses against any type of inequity that COVID-19 response is likely to bring to the fore. And we are seeing in developed countries that the inequities are becoming even more apparent with COVID-19. They're becoming more glaring, and it's going to be the same in Africa. But as Gavin has alluded to, we have been through this road, we have dealt with that, and I think we have a way of leveraging on these intangibles to mount a much more appropriate response. So I think, or if it wasn't the proximity of scientists, policymakers, civil society, implementers, in every conference you'll see them sitting around the table talking to each other. That has allowed breakthroughs to be implemented, to move from research to practice much faster in HIV. And if that wouldn't be possible without concerted efforts and very well described vision that everybody adhere to. If it wasn't for dedicated funding like from the US government and PEPFAR, thanks for the American people, I think it was really amazing to see the amount of investments that went into science. And I want to plug here for science as well, because as we do, you started by saying there's still a lot of unknown. Why is the progress of COVID-19 in Africa different from what we would all have expected? There were doomsday scenario already painted that it's just going to ravage Africa immediately, but it's not happening the same. So I think the same way as we invested in science and research, we have to do that right now. And there is a very big infrastructure of research and research infrastructure in Africa that we can leverage on immediately. So while there's some basic and clinical research going on in developed countries, we should not forget that in Africa, we also have those institutions that can start answering some basic questions. They can start coming up with innovations, pilot testing them and bringing them to scale relatively quickly. So if we go to the quantitative buckets of assets that HIV program and investment has brought to care, I mean, we all spoke about leveraging. If we look at the last PEPFAR report to US Congress 2019, 27,000 healthcare workers have been trained. That's a lot. Hundreds of thousands of community health workers are right now as we speak in the community doing the day-to-day job, be it TB or HIV index testing and tracing, or tracking those lost to follow-up, laboratory systems strengthened for testing that monitor progress of disease, health information and management, health management information systems have been strengthened through investment of HIV, supply chain that will also be needed when it comes to caring for severely ill patients. We have a mature supply chain management for antiretroviral commodities right now. And let me just land on the issue of data as well. We are now using data within the public health system the way we've never used it before. And the amount of accountability that it's brought about, because now funding is linked to targets. Data is analyzed at a very granular level, at site level. Even community health workers, they go to the communities with targets of number of clients that they have to see, and they'll have to account for it. So that kind of accountability in the system will not just fizzle away. And as we do at large scale, the 3 T's, it will be just a pity if we create a system that will be bypassing this, which is running as we speak today. Now, just a few days ago, we were doing a review of performance of our programs in more than 40 countries now. Unfortunately, or as expected, we have started seeing the effect of response to COVID-19 on HIV programs on some indicators. And this is not really, it's not magical, in the sense that we've seen, and we can plot the day in a country where the first case was announced and the moment where lockdown was implemented as a policy in that country, automatically you see a decline, because we look at the run chart, a decline in the number of tests, HIV tests that are conducted in that country, and the number of HIV positive people that are being found. It is not yet hitting other indicators like on retention, which will take maybe 30 or 60 days to show up, but at least on accessing testing, we start seeing a decline in the performance of various HIV programs. Yeah, let me just stop here and say that, yeah, it is something we need to watch out carefully, that as we move forward, we take over the community assets to respond to COVID-19, we should not lose momentum with HIV and TB program implementation.
Yeah, as we say here in South Africa, 100%, Dr. Chabikuli. Yes. Yeah, I mean, time flies when you're trying to chase COVID-19. And, you know, we are almost about to wind up. And before I hand over the baton to Dr. Ogwell, I want to just go back to the 3 panelists, Dr. Professor Chachiad, Professor Abimiku, and Dr. Chabikuli. And maybe tell us in just a few minutes, you know, your final words. But I think if there's one thing we can replicate in Africa with regards to COVID-19, what would that one thing be in your experience and in your great wisdom? Yeah, maybe we start off with Professor Chatiad, and then we go to Professor Abimiku. Yeah.
Very cool, thank you. So I think, I don't know, I would like to see it being replicated, but for me, what has stood out so starkly is the leadership that we have seen in our African countries. And it actually, it's from top down with that, you know, because we haven't just seen an all of government response, we've seen an all of society response. And it's because of the leadership that we have seen. And if we can replicate that elsewhere, I think dealing with this epidemic, despite the challenges, will be so much easier. And just as Otto was alluding to, that we're getting to epidemic control in some countries, we can do the same with COVID-19, but it's going to take strong leadership. All these other biomedical interventions will come in time, but there's so much we can do with what we have now. But to implement them effectively does require strong leadership and coordination. Thank you very much for having me.
Prof. Abimiku, go ahead.
Yes, thank you, Doris. So I think I'm going to lean towards implementation science in terms of what Africa is going to show the rest of the world. We're already getting indications, for instance, that might explain. I still think that testing is really relevant, and until we test the numbers, we really don't know whether this is blunted in Africa or not. So having said that, I think that we're beginning to see some research activities that are coming out, and it's really kind of expected, because we all know that most viral infection is kind of controlled by your innate immunity, and how before your more specific immunity kicks in. And of course, Africa is the grandmother of all kinds of vaccinations, right? And if viruses are kind of related, RNA viruses, we heard recently Robert Gallo coming out and talking about maybe earlier vaccinations against polio, BCG, and whatever it is might activate your immune system, that innate immune system, to the point where it gives you an advantage. So for the African continent, I think it's a continent that can really establish this very clearly, if in fact that is playing a role. So it's very important that we get engaged with the implementation science. And even in the midst of trying to respond to COVID-19 and do what is required for our loved ones that get infected, we must also invest in what it will take us, what will help us to go back and actually do the implementation science when we've dealt with this issue. And I'm speaking specifically of investing in collecting very valuable samples and putting them in biorepositories that are running at international standards that would allow us to go back and address some of the issues and that is specific for Africa, but that will also inform the rest of the world. So I would kind of put my last dollar, my last naira in the bucket that allows us to really use our precious population, our precious samples to go back and do the science when we can. Over. Thank you.
Thank you. And I'll put my Kenya shilling with yours as well.
Thanks so much.
Okay, over to you, Dr. Chapikuli, and then hand it over to Dr. Oguel. Thank you.
From my side, there are two things that we need to keep an eye on. One is information technology. A lot of people are saying, and it could be true, that the world before COVID-19 will be different from the world post-COVID-19. And we can see the type of disruptions that are happening requires very strong information technology to keep people connected, to keep programs going, to keep economies running. So, and I'm just concerned that we're still so far behind as far as information technology is concerned compared to Asia, Europe, and America, that I would just, if there was one advice I would give to government, it is that one: let's invest in information technology so that we'll cope in life post-COVID-19. But finally, the second piece is looking, it's going to lay bare the inequalities and poverty in Africa. because we're looking at it from a health perspective, which is fine, we're going to respond, but the economic implications are coming to face us very soon. We are going to be faced with drought, we're going to be faced with other disasters that will bring food insecurity on the continent. And how do we manage the distribution of wealth in society will be a critical part of the response to this COVID-19. We should keep that in mind. Thank you very much for the opportunity.
Dr. Guel, over to you now. Thank you so much, Dr. Chabikuli.
Thanks a lot, Doris, and a very big thank you to the panelists for making time, to those who joined the webinar for being here to share in this very interesting new reality in our lifetimes. And of course, at Africa CDC, we are very proud to have been co-sponsors of this webinar with FHI 360. And we are looking forward to ensuring that there are even more platforms like this where we can be able to share information and provide direction where Africa can be able to go. As I end, I would like to say three things. The first is the numbers are lower in Africa than elsewhere, but if you look at the confirmed cases, it's been leaping, literally doubling every 10 or so days. And this is a huge cause for concern, particularly when that is juxtaposed with the relatively thin testing that is happening in Africa. As Africa CDC, what we have done is we launched last week PACT, which is Partnership for Accelerated COVID-19 Testing in Africa. And we intend to facilitate the testing of 1 million Africans over the next 4 weeks and 10 million over the next 24 weeks. So this is very key in ensuring that the data that we are receiving is reliable. That way, when we say this is the rate in Africa, it is based on fact rather than the difficulties and challenges that we are facing with testing. This is the first thing. The second thing I would like to say is African governments have come together very effectively in trying to have a joint way of tackling COVID-19. Heads of states meet every 2 weeks. The last meeting was yesterday. Ministers of health meet every week. Ministers of finance meet every 2 weeks. Ministers of transport have met once. We expect they will meet again so that they can be able to provide the policy guidance that will take us towards opening up humanitarian corridors, collaborating, cooperating, communicating effectively so that we are able to tackle COVID-19 properly. And of course, at the third thing I would like to say that at the technical level, we have the Africa Task Force on Coronavirus, which is being coordinated by Africa CDC. And this has proven a very, very important platform where technical institutions on the continent are coming together to provide guidance on what would work. We are adapting what is known out there to the African context, and we are seeing the result of that. Although there's a bit of skepticism about whether we'll be hit really hard by COVID-19, I remain an optimist that what is being put in place, the kind of experiences that Africa has had with other outbreaks, the kind of public health insults, if you want, that our bodies have had to go through over the last so many decades, will be able to give us a little bit of a head start in sustaining the lower rates of transmission that we are seeing. And if we remain disciplined as Africans, if we remain disciplined as governments, if we remain disciplined as professionals in providing the right technical guidance, I think the next 4 weeks are going to be extremely important in knowing and seeing where this particular outbreak is going to take us as Africa. And at Africa CDC, Africa Union, we remain committed and call upon us anytime, and we will be able to provide what we can in terms of guidance and support and political backing to ensure that this curve does not go further up and it remains at the sort of rate that we are seeing now and gets flattened properly. Having said that, my final word is there is nothing that works as well as getting correct information. And for those of us who are in the business of public health, science, we tend to talk to each other using heavy words. It is time for us to translate it into material that can actually be understood by our grandmothers and mothers in the villages, because that is where the battle will be won or lost. We need to slow down on the jargon and up the ante on a simpler language so that we can be able to help Africa keep our numbers low. It's been a pleasure, and FHI 360, I'm looking forward to our next joint webinar, to our very knowledgeable panel. Be sure that you'll be reached out to again so that you can be able to share your experiences, skills, thoughts, and expertise with the rest of the world around not just COVID. I assure you there'll be another outbreak in Africa after COVID, and we look forward to tapping in on your experiences and expertise as we ensure that Africa is better prepared than it has ever been. So it's a pleasure from Africa CDC. Doris, I don't know whether I take it back to you or I take it back to Corey.
I think we're just going to say thank you to everyone for attending, and thank you to the panelists. It was a real pleasure. Stay safe, wash your hands, do everything possible to prevent yourselves from getting COVID-19. Stay well. Yeah, thank you.
Thank you, Doris. Thank you.
Very much. Take care. Bye.
Thank you and bye.